All right. Again, thank you all so much for being here. Are you at risk for stroke with Jamie Warner, registered nurse and nurse navigator with Bronson Neuroscience Center? We are going to start off this class by just giving you this information on the screen on how you can find care and help at Bronson. We have some features at bronsonhealth.com in order for you to search for a specialist or maybe a new primary care provider. If you don't use the website often, you can always call that phone number listed in that first bullet point there, the care advisors, and they can always assist you in helping you find a new provider if that is what you're looking for. If you are using MyChart at all with Bronson and you have any technical issues about using MyChart, Bronson Health Answers is always available for you to get any assistance there. If you have any payment questions, any billing questions, please reach out to our Bronson Patient Accounting. They are there to provide you any answers in regards to billing questions. And last but not least, if you have ever been referred for a service at Bronson and you're just not quite sure how much it's going to cost you out of pocket, we have a price estimator team that you can reach at the phone number listed in that very last bullet point, and they can help you kind of estimate what your cost out of pocket will be for those services. All right, housekeeping out of the way, we are going to send it over to Jamie now, and she is going to talk to us about strokes.
All right, well, thank you, Tina. As Tina said, my name is Jamie Warner. I'm a nurse here at Bronson Methodist Hospital. I'm the stroke nurse navigator. So that gives me the unique opportunity to be able to be involved in our stroke patients' care from the time they are admitted through their hospital stay, and then also after the hospital stay. I kind of act as a navigator or a bridge for patients that are leaving the hospital. I will set up their follow-up appointments, their testing, call patients at home, just become your contact throughout this process to try to make as seamless as possible. And so one of my opportunities with my role is I get to go out in the community and do a lot of education as well. So May is Stroke Awareness Month. So that's why Tina and I are partnering today to bring you this information, because stroke is a medical emergency and early treatment can reduce brain damage and other complications. We want to talk a lot today about, the next slide will kind of go through our key points for stroke risk. So one of the biggest things we want to talk about is reducing stroke risk. About 80% of strokes can be prevented if we can manage the things that are putting you at risk. So we'll go through that today. The other important factor that we want you to be aware of is recognizing stroke symptoms. What are the symptoms of stroke, and what would you do if you were a loved one or someone in the community was having these symptoms? And then the big red box there, respond. At the first sign of a stroke, call 911 immediately is going to be a big message that we're talking about today. And in this presentation, you'll learn why that is so important for calling 911. A little bit of facts about stroke. So it is the 5th leading cause of death in the United States. There's more than 795,000 people in the United States that suffer a stroke each year. On average, someone suffers a stroke every 40 seconds. So during this 1 hour presentation we're together, there's going to be about 90 new strokes that occur just in the US alone. So it's very prevalent and very important that we educate about how we can prevent these from happening. And someone dies from stroke every 3.5 minutes in the United States. There's about 150,000 deaths in the US each year, but about 8 million stroke survivors. There's kind of a disconnect between that number, and that's because it's the leading cause of disability. So as you can see, a lot of times strokes don't cause death, but a lot of times people will have remaining symptoms or disability from their stroke. So it is the leading cause of disability in the United States, and something that we need to really be focused on for prevention. So we're going to have some poll questions here to get us started. Tina, you want to, so are strokes preventable? Tina's going to give you a little poll that you can answer with yes, no, or not sure. So go ahead and click one of those answers.
Yeah, very good. We've got some answers rolling in so far. We'll give us a few more seconds here to get that question answered. Are strokes preventable? And it looks like we have a majority of people are saying yes. We've got 10 people saying yes, strokes are preventable. We've got a few that are unsure too.
Okay, well, is it okay if I display the answer? Okay,
Yeah.
so, oh, not letting me advance.
So can you use your mouse to click on your screen and then go back to your arrow?
Oh, there we go. I'm sorry. The poll was for me as well. So my answer would be yes. 80% of strokes are preventable if we can identify the things that are putting you at risk and trying to control those risks. So the next poll question will be, can a stroke be treated?
All right, poll is up. Can strokes be treated? Yes, no, or you're just not sure? All right, we as a group overwhelmingly think that yes, strokes can be treated.
Well, good. I am happy to see that response because they do require emergent treatment. Many, many years ago, there weren't as many treatments available. So now that we've had a lot of advancements in medical care and the treatment of stroke, there's a lot of things we can do. A lot of them are time sensitive, and we'll go through that today in the presentation. So that's why we are so adamant about 911, because we want you to be eligible for those treatments if it's appropriate. Next question, do strokes only occur in the elderly?
All right, poll is up. Do strokes only occur in elderly people? Yes, no, or not sure? All right, no fool in this group. They said no.
Good job, everybody. So that is correct. A stroke can actually happen at any age. We are seeing a rise of strokes in the younger populations. And so we're going to talk about that today too, but they do more often happen in the elderly population, but they can occur at any age. So next poll question, does a stroke happen in the heart?
All right, poll is launched. Does the stroke happen in the heart? Yes, no, or not sure? All right, overwhelmingly, we've got the answer of no. One person has said yes, and a couple not sure.
Yep, you guys are doing awesome. So a stroke occurs in the brain. So the heart can play a role in stroke. We'll talk about that today. The heart and the brain do communicate a lot, and they can play a role in stroke together, but the actual stroke is something that's occurring in the brain. And then the last poll question, does recovery from stroke end after 6 months?
All right, poll is up. Does stroke recovery end after 6 months? Yes, no, or not sure? All right, they're quick to answer. We've got an overwhelming answer of no with a couple that aren't sure.
Good job. Yep. So stroke can last a lifetime. We will discuss today that the first 3 to 6 months is when the brain goes through the most healing and recovery. But beyond that, there is still opportunity for recovery lifelong. So we can still see that even after that amount of time. All right. So I'm going to close the poll here. So let's talk about what is a stroke. So stroke is a lack of blood flow to the brain caused by a blockage or a rupture of a blood vessel. So the picture on the left is called an ischemic stroke, and it's when a clot blocks blood flow to an area of the brain. So if you can see my picture here, there's a little arrow pointing to where that red area kind of stops, and then the area beyond that is all this gray tissue. So when an ischemic stroke occurs, it causes blockage to your blood flow, and your brain always needs blood flow. That's how it continues to perform the way it needs to. It needs that blood flow and oxygen. So once that blockage occurs, it starts to cause damage in the tissue that's not getting blood flow right beyond it. So you can see in there, that's that tissue that's gray. That is the stroke, is that lack of oxygen. And then a hemorrhagic stroke on the right. So hemorrhage means bleeding. So this would be a stroke that's caused by bleeding that occurs either inside of the brain or around the brain tissue. So an ischemic stroke we'll talk about first. It is a blockage of blood flow to the brain, and this can be caused by either plaque built up within the vessel or plaque that breaks off and travels into those vessels, or a clot that travels from somewhere else, usually the heart. So that poll we talked about, the heart can still play a role because a clot can form in your heart and then travel to the brain. This is the most common stroke that you will see. About 87% of strokes fall into this category. And there's a couple different types of ischemic strokes. There's thrombotic or embolic. So let's review what those terms really mean. So a thrombotic ischemic stroke is when there's formation of a blood clot within the brain due to hardened buildup that we call plaque. So you can see on the left, there's a really nice clean artery. The blood's flowing nicely, everything is smooth. But then on the right side, there's that artery that looks like it's got that yellow buildup. We call that atherosclerosis or plaque most commonly. And when that plaque builds up, that's usually due to risk factors like smoking, high cholesterol. And when that happens, that yellow buildup either can have a piece break off and then travel upstream and cause a blockage, or it can get so clogged that it just completely blocks off right in that area. This can happen in the brain. Sometimes that blockage can be in your neck as well, and then that's stopping blood flow from going up into the brain. The embolic stroke is when a blood clot travels through the bloodstream to the brain from somewhere else, most likely the heart. I don't know if those of you in the audience have heard of something called atrial fibrillation or AFib. Some of you may have it yourself, know of a family or friend that has that. But with AFib, the heart can go in and out of this irregular heart rhythm. And when that happens, blood isn't being pumped as efficiently as it should because it's not having that nice normal rhythm like we want. And so during that time, a blood clot can form in the heart, and then it eventually is pumped out and it travels up to the brain and causes a blockage. So you can see in these pictures here, this blood clot kind of getting lodged into that bigger artery as it enters into the brain. So hemorrhagic stroke, if you remember, hemorrhage means bleeding. And so it's when a weakened blood vessel bursts or leaks blood into the brain. Only about 13% of strokes fall into this category, so they are less common, but the symptoms of stroke, whether it be due to a blockage or whether it be to bleeding, are the same. So we don't know what's causing your symptoms until you come in and have more advanced imaging completed. And there's two types of this bleeding type stroke as well, an intracerebral hemorrhage, ICH for short, or subarachnoid hemorrhage, or SAH for short. And so we'll get into that, but you can see in my picture here, when that rupture occurs, you're not continuing to have the blood flow you need. So again, it causes that gray tissue, which is damaged tissue because it's not getting the blood flow that it needs. With an ICH or intracerebral hemorrhage, think of intra meaning inside. So it occurs inside the brain tissue. The most common cause of this is high blood pressure. If you can see the pictures below the brain, there's a normal vessel. And then in the middle, there's something called a bulging vessel. So if you have high blood pressure and it's putting a lot of pressure on your vessel walls, they're going to start to become a little weak and almost have that ballooning effect. And so when that happens to the point where it gets so weak, it has a burst. And you can see that on the third picture there, there's a burst or that blood starts leaking into the brain tissue. And then a subarachnoid hemorrhage or an SAH is still bleeding, but it's more describing the location. So subarachnoid hemorrhage just means it's in the subarachnoid space, which is the space between your brain and your skull. On the picture there, there's a little square kind of showing that. And so again, it's most commonly going to be caused by an aneurysm that ruptures. So not necessarily a vessel like inside the brain, but an actual aneurysm that has formed. Some people are born with aneurysms and have them their whole life and never, know that. Sometimes an aneurysm can develop over time with risk factors like high blood pressure, smoking, those types of things. But it's more specifically describing where this is occurring. And then a transient ischemic attack or a TIA. A lot of people have heard this term referred to as a mini stroke. I really try to educate people that a TIA is different from a stroke because it doesn't cause any permanent damage to the brain. A mini stroke just makes it sound like you had a stroke that was small. But a TIA is actually where there's temporary blockage of blood flow to your brain, but your brain is able to get blood flowing again, and it doesn't cause any of that permanent damage or that gray tissue. So it's more of a warning sign of a future stroke is coming. And so we still treat them very seriously because up to 40% of TI patients will have a future stroke. So if you have symptoms of a stroke that maybe resolve themselves within a few minutes or hours, we still want you coming to the emergency room because there's something going on that's causing a change to blood flow to your brain. Thankfully, everything resolved and didn't cause that permanent damage, but we got to figure out why are you having these symptoms and how are we going to try to reduce risk of a future stroke to occur. And the symptoms of a TIA and a stroke are the same. If you started having these symptoms, we don't know if they're going to resolve on their own or not. And so we need you to go to the ER to get more emergent treatment. And so typically with TIA, your symptoms will completely resolve within 24 hours and your MRI or your pictures of your brain don't show us any permanent damage. So there is a difference between that transient ischemic attack or TIA and a stroke. So it's important to be fast. So if you've seen this up in our hospital or on our website, we really try to educate patients on the symptoms of stroke because not everyone is aware of them. And many people are aware of FAST. That's been around for a very long time. But in the last few years, a lot of organizations are adding that be fast to their acronym because there are symptoms of stroke that are less common or not thought of right away as stroke, meaning that B for balance or E for eyes and vision changes. Not everyone immediately thinks stroke with those symptoms. And so we don't want those to get overlooked or not treated seriously. And so B is balance. And with stroke, we're looking for something sudden. A lot of people, when I do my talks, will say, well, I've had vertigo or I've had balance problems forever, or my vision is not good. With stroke, it's an abrupt change to your baseline. So kind of like think about a hose that's running and you kink it off. Think of that as your blood flow. As soon as that changes, these symptoms are going to develop. So it's not something that's gradually come on for months or years. It's something that's abruptly new or worse for you. So balance would be loss of balance or coordination, like you're walking. Headache would be worst headache of your life. So not headaches that can be very common for people, but it's abruptly the worst headache you've ever had is usually how people will describe that, or they feel very dizzy. E is eyes. So again, blurred vision is listed, but also if you have sudden loss of your vision or any doubling of your vision, that's a very new symptom for you. F is face, so drooping of the smile. So if someone smiles and one side is not symmetric or one side is drooping down. A is arm, so any weakness on one side of your body. It can be your arm or leg or both, or if it's numb or tingly very suddenly on one side. And then S is speech. If you suddenly can't get words out or they're slurred or garbled, a lot of times people with speech deficits don't recognize it themselves. They may not realize what they're saying is not making sense. So a lot of times it's family or friends that are picking up on these odd symptoms for a patient with their speech. And it doesn't have to be all of these. If you develop any of these symptoms, new or worse, then that T stands for time. It's time to call 911 right away if these are occurring. So why 911? Why not drive myself or have my family member drive me? They can get me there faster. So the reason for that is that the EMS staff or the emergent medical services staff that come with the ambulance can start treating you when they arrive because time is very important. So they can evaluate your symptoms very quickly and realize that you're having symptoms of a stroke, and they will get you to the hospital they know can treat that appropriately. And they can start treatment if you need an IV started. If you have trouble breathing, they can provide oxygen. They can start lowering your blood pressure. There's just a lot of things that can be done en route to the hospital. And the biggest advantage is that when you're taken by an ambulance, they call us and they say, we have a stroke patient coming in. We're going to be there in 11 minutes. And so our team is there waiting for you when you get here. We all get a page to our phones that says that you're coming. And so they have the neurologist there waiting for you. The CT scanner is cleared just for you, because we know this is something we want to address very quickly, rather than you driving yourself or going into the waiting room and maybe possibly not getting triage as we'd like and having you wait. We want to just get you kind of bypassed through all of that right to your care. And the stroke team will ask you a lot, when is the last time you saw that yourself or someone else without symptoms? This is known as your last known well. A lot of people wonder why we keep asking this question. And the reason is because it will help us decide which treatments are best for you and which treatments you're eligible for, because a lot of treatments have certain time frames of when they're safest to provide. And why don't people come in? Some people don't recognize the symptoms as being stroke. Other people are in denial, thinking it may go away. They'll see if, they think it's something else causing it, or they want to lay down and take a nap, see if it will go away. Some people think nothing can be done for stroke. They worry about the cost. That is a big factor for people, because hospital bills can be expensive. They think the symptoms will just go away on their own, or they fear or don't trust hospitals. But time is brain. So on this slide here, you'll see how significant it is to get fast treatment, because every minute that your brain is not getting that oxygen, almost 2 million neurons are destroyed. And if you see in that last bullet there, it says, compared with the normal rate of neuron loss and brain aging, the ischemic stroke, or ischemic brain, which means brain that's not getting oxygen, ages 3.6 years each hour without treatment. So what that's saying is that it's going to speed up the brain's aging by 3.6 years every hour that it's not getting the blood flow that it needs. So what are these treatments that I keep referring to? So with an ischemic stroke that's caused by a blockage or a clot, the first thing we do for anybody is we do a CT scan, because that's going to tell us if there's any bleeding. If we don't see any bleeding, then we can consider something called a clot busting medicine. Some people know it as TPA, TNK, or that clot busting medicine. And that medicine can only be given within the first 3 up to 4.5 hours after your symptoms have started. So that's why we ask a lot of times, when did this start? Because if they started at 9 o'clock, we know that we can only give that within the next 3 to 4.5 hours from that time frame for it to be safe. Even if you are outside of that window, we still want you to come in, because sometimes patients will need to have something called a thrombectomy, which really just means a clot retrieval. Certain strokes that are large enough in large enough blood vessels, we can actually go in with a catheter through your groin and pull that blood clot actually right out with that catheter. And so that can actually be done up to 24 hours after symptom onset. And so it doesn't always mean if you're out of that first window that you're not going to get treatment. We still want you to come in right away and see what's going on, what type of stroke are you having, so that we can get you that care right away. So just some data from Bronson, just to give you an idea of how quickly we're trying to do things. The Joint Commission is a group that has put together certain standards of how quickly we should be doing things as a goal to provide the best treatment. So from the time you get to the hospital to the time you receive that clot busting medicine, the national goal is to get that within 60 minutes or 1 hour. You can see at Bronson, we've done a lot of work to figure out how can we do that fast. And so in last year's data, on average, we were giving people that medicine within 27 minutes. So you can see from year to year, we keep getting better because we keep figuring out ways to make this more efficient. And then for that clot retrieval procedure, or thrombectomy, the goal is from the time a patient gets here to the time they're actually getting the procedure done is 90 minutes. And so you can see in the last few years how much time that we've taken off of our data, because we are finding other ways to make things very efficient. And the whole goal of this is that we want to save as much brain tissue as we can. So last year we were doing that on average of about 63.5 minutes of patients getting that surgery from the time that they arrived, which is really, really amazing work. Then the bleeding stroke. So hemorrhage again means bleeding. So for those, there's a different type of treatment that we would do. So in these pictures, if your stroke is being caused by an aneurysm that burst, on the left, you see something called clipping. So they can actually go in and place a clip at the base of that aneurysm, which would then prevent more blood from going into the aneurysm and continuing to leak. The other type of procedure we can do is something called a coiling, and that's on the right. So you can see this catheter going up through the artery and up into the aneurysm, and it just looks like they keep swirling and swirling and swirling. They're basically packing this aneurysm with this coil in order to stop the bleeding. So those are two emergent things we can do for an aneurysm. If the bleeding is inside of the brain, then really the biggest thing we want to do is get your blood pressure down to stop that blood flow or stop that pressure from adding more risk. And really that's a lot of times done through IV medication. So again, not something we can do at home. We need you to come in so we can get that blood pressure down very quickly. So for Bronson Methodist, we're very proud to be a comprehensive stroke center, which means that we can offer all the services that we would need to provide any type of care that someone would need. It's certified through the Joint Commission. They come visit us and we kind of show them our program, show them our data, and they will give us feedback if there's things we can work on. And we've had this Gold Plus, meaning the highest level of care we can provide, the highest standard, basically. We've been receiving that award since 2015. So we are very proud of the work we're doing here at Bronson. Not to brag, but we're just very proud of what we're doing here for our stroke patients. And Bronson Battle Creek. We are very proud of our hospital in Battle Creek as well. They're now an acute stroke ready hospital. Again, the Joint Commission is the one to award that. And that is where they can provide certain treatments in their emergency room. And then if they need a higher level of care, they can be sent to Kalamazoo to receive additional treatments if needed, but they can be stabilized and treated very well there at Bronson Battle Creek. So what does it mean to be a comprehensive stroke center? Just as a background, if people are interested in knowing what that really entails. So we have to have a neuro intensive care unit for our stroke patients that's open 24 hours a day, 7 days a week. We have to have advanced imaging capability, which basically means we can do MRIs, CT scans, use any type of pictures that we would need available. We are always participating in stroke research. So the way that we've been able to improve our data is through research. So we like to be a part of that. Coordinate care of stroke patients after they discharge from the hospital. So my role was actually created to meet this need. So I only focus on stroke patients. That's my whole job, is I am basically just coordinating care of that specific group, and that was a requirement. And then we demonstrate high quality care by our nurses and doctors. Our nurses and doctors that work with our stroke patients, they get an additional training every year for stroke specifically. So in addition to all the other training they do even more specialized training to care for stroke patients. And we have to be able to care for those subarachnoid hemorrhages, like what we talked about with the clipping and the coiling and giving the clot busting medicine. We have to be able to provide all of that. So with stroke recovery, about 10% of stroke patients will recover completely, no symptoms at all. 25% will maybe have some minor impairments if they know that they're not all the way back to their baseline, but pretty much back to their normal routine. About 40% of people will have moderate to severe impairments requiring special care, like physical therapy, occupational therapy. And so that's the biggest majority of people are in that group. 10% will need to be in like a long-term facility or skilled care facility. And then 15% of people can unfortunately pass away shortly after the stroke has occurred. But most people are in that moderate to severe impairments. And so for stroke recovery, the biggest thing that we can do is rehab. And when I say rehab, that means physical therapy, occupational, and speech therapy. Not everyone requires all of them. It just really depends on what symptoms that you had and what you need to work on. We will have all three of these services see you while you're here and determine if you would benefit from those services ongoing and at what level. So physical therapy means like your walking, your range of motion. Occupational therapy is, we call it activities of daily living or taking care of oneself. So think of that as like, we want you to be able to brush your teeth, comb your hair, button your shirt, make a meal. So it's really more getting you back to your normal day-to-day routine, and how can they help maximize that. And then speech therapy is more about communication, like you're talking, your swallowing, and your cognition, so your thinking, are all things that speech therapy really focuses on. So what can we do? I know we talked about in the poll, 80% of strokes can be prevented. So how can we do that? So high blood pressure is the biggest risk factor for all types of stroke, ischemic or hemorrhagic. And so we want you to have it checked at least yearly. But a lot of people now will have their own cuff at home, which is great because some people will have high blood pressure and not know it. They don't always cause symptoms. So it's good to have that at home, to be checking periodically. Our goal long-term is about 130/80 or less. Work with your healthcare professional if they have certain goals for you, but that's in general what we like it to be at. Atrial fibrillation or AFib. That was from the picture at the beginning where the heart can play a role in stroke, because this isn't a regular heartbeat. And if you have that, you're 5 times more likely to have a stroke, because when your heart is in that irregular beat, it's not pumping blood like we would like. And so blood is sitting too long and forming a blood clot. And so follow your doctor's recommendations to treat AFib. There's a lot of things out there with different medications or different procedures that can be done to help your heart with atrial fibrillation. So it's very important to be taking those medications as prescribed. High cholesterol. If you've had an ischemic stroke or TIA due to narrowing of the blood vessels, the bad cholesterol, also known as your LDL, we like that number to be about 70 or less. And if it's high, work with your doctor. We do a lot of different medications, also diet and exercise, which Tina will talk about today. For diabetes, over time, increased blood sugar levels can lead to these fatty deposits or clots inside the blood vessel walls, and that can narrow or block your blood vessel, which can lead to a stroke. So it's important with your diabetes to have that well controlled as well. If you smoke, I don't have any other recommendation except stop, because it does double your risk of stroke, and there's really no amount of nicotine that's been considered safe. So talk to your provider if you want to quit smoking. There's a lot of different resources out there. If you drink alcohol, do so in moderation. So limiting to 2 drinks in a day for men and 1 drink in a day for women. Drinking beyond that just can increase that risk for that irregular heartbeat. It can raise your blood sugar levels, raise your blood pressure. So just trying to be moderate. I'm not saying if you don't drink at all to suddenly start drinking 1 or 2 drinks a day. And I'm also not saying to add these up throughout the week and then do them all in one day. I get that a lot when I do these talks. So don't change any habits if you don't drink at all or anything like that, but it would just be, that's what's considered moderate use. Drug abuse is something that we still do commonly see. Cocaine, amphetamines, and heroin can cause the blood pressure to rise very quickly, which can lead to those bleeding type strokes. And then marijuana use over time consistently can damage blood vessels and increase your chance of forming a blood clot. So enjoy regular physical activity. Try to get at least 2.5 hours or 150 minutes total in a week. So we're saying that you can spread that out. We'd like each activity you do to be at least 10 minutes, and try to get your heart rate up when you're doing that. And it should be spread out throughout the week. So don't just do 150 minutes on Saturday and then be sedentary the rest of the week. So we're trying to spread it out. I tell people do something they enjoy. If you try to do a program you don't like, you're most likely not going to stick with it. And maybe get a buddy. If you do walks, after dinner or whatever you guys enjoy, find something that you will stick to. You're more likely to be successful that way. And I like this cartoon. It says, I can't get out of my bed. My Fitbit is charging and my steps won't count. So I like that because a lot of people now wear Fitbits or Apple Watches, and it tells you your steps, or it tells you, hey, you got to get up. I get that all the time. I'm working at my desk and it says, you need to stand. And so these are good ways to have that acknowledgement of needing to stay active. I'm not going to go too deep into this because Tina is the expert, but the Mediterranean style of eating can help reduce risk of obesity, diabetes, high cholesterol, high blood pressure. It's a lot more plant-based meals and healthy fats and limiting added salt and processed foods. So Tina's going to talk about that at the end of my presentation. One thing to note is that after a stroke, some patients do have difficulty swallowing. And if you do, you need to check with your provider or your speech therapist to see, do you need a special type of diet with special consistencies? Do you need your liquids thickened to swallow them safely? So just something to be mindful of. This is a really good picture of a Mediterranean plate, which I'm sure Tina is gonna get into more. So there's some things that we cannot control. And so even though we can't change them, it's good to be aware of them. So race and ethnic background does play a role in stroke. There are certain groups, which you can see listed there, Black Americans, Hispanic Americans, American Indians, and Native Alaskans have a higher risk of stroke. The reason why these people are at higher risk is not quite clear, but we think it's because they have a higher incidence of the risk factors like high blood pressure, diabetes, obesity, and sickle cell anemia. So it kind of goes with that stroke risk. And Spanish-speaking Hispanic Americans are less likely to know the symptoms of stroke over an English-speaking Hispanic American. Age, again, it can happen to someone at any age, but it does get higher as you get older. And strokes can happen in younger adults. 10 to 15% of strokes actually are occurring in that 18 to 50 age range. And about 1 in 3 younger adults don't even know the symptoms of a stroke, or they would ignore them if they're happening because they don't think it could happen to them at that age. Some unique things for this age group. Pregnancy can increase blood pressure and put you at risk for gestational diabetes. Hormone treatment containing estrogen, like blood pressure pills or any hormone treatments, can increase risk of blood clots. There's some clotting disorders that are more prevalent in younger adults. And then there's something called the patent foramen ovale, which is a hole in the top chamber of the heart that some people are born with that can cause strokes at a younger age. Your family history can make you at higher risk if it's a parent or a sibling. So if it's a cousin, an aunt, an uncle, not the same as if a parent or sibling had that. And the reason for that is a lot of times risk factors for stroke can run in families. So it can happen with that immediate family. And about 1/3 of people who have had a TIA will have a stroke within a year. And if you've had a stroke, your risk does go a little higher. A lot of people want to know an exact number. Well, what is my chance I'm going to have another one? I tell people it's kind of hard because think about if 2 people had a stroke, they both smoke and they both had high cholesterol. One person doesn't quit smoking, doesn't take their medicine, doesn't change their lifestyle. One person quits smoking, takes their medicine, diet, exercise, makes those changes. Their risk is going to be different. And so it's really dependent on what caused your stroke and what are we doing to lower that risk. Support groups are huge because this is a big life change that happens very suddenly. So support groups can be great for families or just the patient or the caregiver. We do offer a support group here at Bronson in person that meets once a month, and it's also virtual. So you can join just like how you guys are joining today. And if you want more information on that, that is on our website. And then if you also wanted to find a support group in your area, maybe you know of a family member that lives out of state that had a stroke. If they go to the Stroke Association website, there's a place you can type in your zip code, and then it would show you any registered support groups that are near that zip code. So it's a cool tool to be able to try to find registered groups near you, because a lot of times you don't even know what's out there. So it's a good way to look for those resources, and a lot of people find benefit from being with other people that have had a stroke. Now I'm going to give it over to Tina.
Thank you, Jamie. That was super informative, and I really appreciated the visuals. I am actually putting a link right now into the chat for the Bronson stroke support group. So there is a link in the chat now, so you can get some additional information on how to sign up and when the stroke support group is meeting. So that link is in the chat. All right, we have had some good questions come into the chat as well, Jamie. We're at 9:42. I am going to peruse through this information relatively quickly to give a big picture overview of what the Mediterranean diet is and how it plays into the information that Jamie has presented to us so far. Please know that on our Bronson YouTube page, there are 2 other recorded Mediterranean diet presentations that you can go back and get some more in-depth information on. So let's move forward in talking about the Mediterranean diet. And Jamie, will you advance my slide for
Oh,
me?
I'm sorry. My fault.
Thank you. All right, so the Mediterranean diet, there is a lot of buzz around it for valid reasons. It has been ranked the best overall diet for the last 7 years in a row. Additionally, in this last year, and for many years previous to this, it has also been ranked #1 best for heart healthy diet, which is very specific, obviously, to what we're talking about today. And it's also been ranked #1 for the best diabetes diet, which is also very specific to what we're speaking about today. So let's move forward and talk about why that might be. So when I say diet, right, I think we probably have a bit of a negative thought around the word diet, but that is not what the Mediterranean diet is at all. The Mediterranean diet is not prescriptive in any way, right? It's not telling you that you can't eat this or you can't eat that, or you can only eat this in certain portions. It's really a style of eating. It's an encouragement of what we want to include most often in our diet. So don't think that they're going to get very specific recommendations of how to eat within this Mediterranean diet, but a big picture overview of the things that should be included most often. How are we eating most often? That's the pattern of our eating behavior. This is a food pyramid that comes from Old Ways. I am going to provide you guys with some links at the end of class to connect you to Old Ways and some additional resources so you can continue to learn. But if we look at this visual of the Mediterranean diet pyramid, we can see at a big picture overview what we want to include most often in our eating pattern, right? The biggest part of that pyramid is plant-based foods, which Jamie mentioned earlier, right? We want mostly plant-based meals. And by plant-based, I am referring to our fruits and our vegetables, but also our whole grains, which we're going to talk about here in a second as well, our nuts and seeds. You also see that this big part of the pyramid includes olive oil, which is a crucial component to the Mediterranean diet, and sodium-free seasonings. When we talk about hypertension and that putting us at risk for stroke, we want to be mindful of how much salt we're adding to food. And so on the Mediterranean diet, there's a lot of sodium-free seasonings, providing flavors with fresh herbs and spices that do not have any salt. We will move forward and kind of break down each of these pyramid layers. So every meal on the Mediterranean diet is based around plant food. So when we're thinking about how do we want to do more Mediterranean diet meals, we think about our base being fruit, vegetable, whole grain, beans. When I say legumes, I'm referring to beans and not green beans, but like black beans and garbanzo beans. Lentils are considered in this category as well. And then seeds, things like chia seeds, sunflower seeds. How can we get more of those components as the main primary base of all of our meals and snacks? Then when we're talking about protein, right, on a Western style diet, we typically think of protein as being things like our red meat choices. But on the Mediterranean diet, that next layer of that food pyramid is protein coming from fish and seafood. Fish and seafood do not have nearly as much saturated fat as some of our red meat choices, and therefore can decrease our risk of that plaque buildup that Jamie was referring to. And it can also decrease our risk of heart disease overall. So fish and seafood choices that are used quite often on the Mediterranean diet are things like tuna, which I would recommend a light tuna to decrease your mercury intake. salmon, sardines, cod, flounder, shrimp, trout, all very good options. Some of those higher in unsaturated fats or omega-3 fatty acids than others, but all good choices. And in the Mediterranean diet, it is recommended to use this often as our protein sources. At least 2 to 3 times per week, we should be having a serving of fish. Then from there, we think about other lean protein choices. And by lean, I'm simply just referring to the fat content. So things like skinless poultry, so skinless chicken or turkey, plain Greek yogurt. And then in the Mediterranean diet, there's a lot of use of other cheese that maybe we don't use as often, and maybe we do sometimes, but like ricotta, feta, and goat cheese. These protein sources and dairy sources are used in moderate portions on a daily to maybe a few times a week form of basis. Red meat and processed meat, which tend to have a lot of that saturated fat and also tend to be very high in sodium when we're talking about the processed meats like hot dogs, sausage, bologna. That is not seen often at all on the Mediterranean diet. So the very top point of that pyramid, we are using these forms of protein choices sparingly, less often, not our primary protein source on a Mediterranean diet. In desserts on the Mediterranean diet, we think of desserts being very high in added sugars, right? Brownies, cakes, ice creams, cookies. Jamie mentioned that diabetes can increase that risk of stroke as well due to high blood sugar also causing that increase in plaque buildup. So we think about these added sugars and how that can play a role in any sort of diabetes or blood sugar control if you're currently living with diabetes. Those forms of desserts are not used often on the Mediterranean diet, but instead, fresh fruit. And I know that sounds kind of boring, right? Just to have an apple, but it's not always like that. We can bake fruit, we can grill fruit to make it a little bit more exciting. And so there is many recipes out there for dessert options that are lower in added sugar that could be helpful. And then olive oil. Again, olive oil is the primary added fat on the Mediterranean diet. So we here in the US may use things like margarine or butter most often, but olive oil, really, we need to work towards replacing butter with olive oil. Extra virgin, cold pressed are the words that you want to see on the front of your olive oil bottles. Very high in antioxidant properties when we do extra virgin olive oil. Some of the recommendations here are not to buy them in large quantities. So don't buy a big jug of extra virgin olive oil. Instead, just buy smaller quantities that you know you're going to be able to use in the next 2 to 3 months, because every time you open up that container of olive oil, it's being exposed to air, and that air is decreasing the antioxidants in that olive oil. And heat and light will do the same thing. So store your jar or container of olive oil in cool, dark places away from any heat sources. Extra virgin olive oil can be used for things like sauteing and grilling. Even a shallow fry, like if you're doing like a piece of fish and you want to just do a little fry on it with some extra virgin olive oil, you can use extra virgin olive oil in that way. So what are some small changes you can make, right? Again, Mediterranean diet is not super prescriptive. It's a big picture overview. Ask yourself the question, how can you make changes to your current meals and snacks that increase your fruits, vegetables, whole grains, and legumes, right? You might have eggs for breakfast. How can we get some sauteed vegetables into those eggs, like bell peppers or spinach or tomatoes? Can we replace one of our hamburger or steak offerings throughout the week with a salmon or a flounder or even a bean-based meal? Swapping out white rice for things like a quinoa or a lentil, think stir fry. You've got your chicken, good source of protein, lean, you've got all your vegetables with that. But instead of white rice, try using quinoa instead. It cooks just like rice, takes a little bit longer, but you can use it as a simple replacement that has more fiber, more plant-based protein instead of a white rice. Using hummus could be an option to use for a dip for vegetables, or use that as a spread on sandwiches or wraps. Choosing oatmeal, adding your nuts, your seeds, or your berries, just some very simple ways to work towards having more Mediterranean style meals and snacks. And then last, I'm going to provide you with some cookbook recommendations. If you've come to any of my other Mediterranean diet classes, you've seen these cookbooks before. I own both of them. The Complete Mediterranean Cookbook from the America's Test Kitchen is very extensive, 500 recipes included in here. And there's a lot of cooking information, like how to prepare quinoa, a little bit more specific. Next cookbook you will see is a little bit more simple. 30-minute Mediterranean diet cookbook. The authors of this 30-minute Mediterranean cookbook are 2 registered dietitians. Simple, easy to use ingredients, 101 recipes here. And then moving forward, we've got some links, and these are the resources that I'm going to provide to you in the chat. We can continue on here. I'm going to put these links in the chat, but we're going to stop the recording now so we can get some of these questions answered. So thank you guys so much. I am going to stop the recording.